Good to see you. Good morning, Whitney and Michael Ruttenberg.
I think she put me as a co-host somehow.
Oops. Yes.
That's a lot of power to give me.
Oh my gosh.
It is 9 o'clock, but we'll wait just a moment for a few more folks to join before we get started.
Carrie Paczynski.
I'm on it, Tasha.
Okay,
Thank you.
you're welcome. I appreciate you guys.
Okay, I think we'll give it about one more minute just for a few more folks to join.
Good morning, Michael. Good morning, Kari.
Morning, everybody.
All right, it looks like we have majority of our council, so we will go ahead and get started. Sandra, if you wouldn't mind sharing the agenda to your screen. Good morning, everyone. Welcome to the Behavioral Health Administration Advisory Council on this kind of cloudy, feeling like winter, November 20th day. I am Megan Shelton. I go by she, her. I am the Culture, Practice, and Accessibility Advisor for BHA, and it is my honor and privilege to support this advisory council. So with that, we will jump into just a couple of logistics. Sandra will go back to sharing the agenda in just a minute, but wanted to bring your attention to our meeting packet. All council members have this meeting packet. It is in our drive and also in the prep email that you all received. So you can please review this every once in a while so that you're aware of it. There's a section on ASL interpretation. And how to access the screen reader for interpretation for American Sign Language. And then if you want to slide down a little bit, Sandra. There's also closed captioning has been enabled. And then keep on going. Just wanted to talk briefly about, we have group agreements that the council voted on. So make sure that council members are following the group agreements. We do encourage all council members to stay on camera and participate in the session. We do understand on occasion there are sometimes difficult topics that come up, and it's okay to turn your camera off and take space for you in those moments as well. Okay, if you want to go back to our agenda.
I think these are the minutes. on, let me see if I can find the agenda.
Actually, the agenda's perfect. I'll turn it over to Tasha to do roll call for us.
Good morning, council and members of the public. Danielle Ngotti.
Present.
Dr. Rob Archuleta.
Present.
Preston Berry. Whitney Butcher.
Here.
Raquel Garcia.
Present.
Anaya Hall. Carolyn Hall.
Here.
Tasha Conker is present. Judge Elizabeth Leith,
Is absent today or may step in later.
excuse.
Mhm.
Lindsay Mish or Moush. Yeah,
Mish.
sorry. Thank you.
Thank you.
I
Yep.
apologize about that.
That's okay.
Maria Martinez. There. Keith Parker or Maria Nagel.
Here.
Keith Parker. Carrie Paczynski.
Here.
Antonio Pito.
Here.
Michael Ruttenberg.
I'm here.
Jennifer Silva is excused. And Catherine Washington.
Good morning, I'm here.
Good morning. Thank you. I'll turn it over to Raquel.
Good morning, council. We will take a moment and review the agenda. We'll start off with reviewing and voting in the October meeting minutes. Then we'll move on to the commissioner update this morning. Then we have some council business. We'll have a break at 9:40. We'll come back and review the governor's November 1st budget release. And we'll talk about close the conversation with workforce and then open up for public comment. So in order of the agenda, has everyone had time to review the meeting minutes? And were there any changes or adjustments that were needed to the previous minutes? I'll open it up for discussion. Carolyn?
So at the very end of the meeting minutes, in your name, Garcia, there's 2 A's. I don't know, it's a typo. I don't know. I just wanted to share that.
Nice catch, Carolyn. Thank you. We'll get the spelling corrected for that. Anything else? I'm looking for a motion to approve the October 2025 meeting minutes as is.
Tasha Conker, I motion to approve meeting minutes.
Looking for a second.
I'll second.
Mhm. I can't, all I saw was Carolyn, but I'm not sure who else also second.
Maria Martinez.
Oh, thanks, Maria. Yeah, it's strange, my screen. Zoom's been weird this last 30 days. It only lets you see so many people. All those, we'll do it by opposition. Anyone opposed to the meeting minutes? See is that there's no opposition to the meeting minutes for October. The meeting minutes are approved as presented. Those will be filed. Thank you so much. And I get to introduce the Commissioner of the Behavioral Health Administration, Miss Dana Smith. It is your turn, ma'am.
Okay, good morning, Raquel, and good morning to the council this morning. So glad to be here. And I think there are 3 areas that I just kind of wanted to update you on. One is we are getting ready for our JBC hearing. Our JBC hearing will be on December 16th. So we would love for you to be in the audience or at least send some well wishes up. We have 4 decision items that will be going before the JBC, as well as we want to kind of give an overview of where we've been over the course of this last year. and where we hope to go for the future. And as many of you know, a lot of that is going to be strengthening the work that we're doing within the BHAAC. So that's going to lead me right into the discussion of the BHAAC. The BHAAC model is going very well. We are seeing people reach out. There are 3 tiers in which the community can reach out for services. And the first one is simply through a call with us assisting with navigation. The second one is, or maybe more of a referral, and I should say a warm handoff. That's tier 1. Tier 2 is with some slight case management services where we will navigate with you the right provider that we believe can provide the services to you. And then the third one is a really in-depth assessment, case management before any handoff is done. We want to make sure that what we are hearing from you in a time of when you need behavioral health services, we are actually addressing. So that's going well. We are up to about 350 calls that have come in. The majority of the calls are at level 1, where they simply need referral to the right particular provider to provide behavioral health services. The other thing I'm learning too is that, because I was a little concerned about our numbers being so low, what I'm learning is that there are a lot of people who are using OnPath as a way to get information. And this is through Colorado Lips now. We don't use BHAAC anymore. It's through Colorado Lips. But it's called Colorado Lift, powered by OnPath. And that's our technology system that can actually give you all the providers who are in our network that can be utilized. What I'm learning is that there is a steady stream of people who are using Colorado Lifts and not even calling our BHAACs to be connected to services. People are doing it on their own. So I'm testing a hypothesis that maybe the reason why I see the low numbers is because people are accessing services as much as they can on their own. If they get stuck, I'm thinking that that's when they call in, and they call into one of our Colorado Lift providers to get the information. So that's what's going on with BHAAC. Raquel, you look like you got a question.
No, I'm thinking of the pathways, and then I was also thinking, and I think people also access services in different ways, right? Whether it is through us to get to the BASO or however is providers. So
correct.
Just my brain's thinking, no, nothing in particular.
Yeah, and I think that was something new for me to learn, because I think what I had envisioned is that people would call the 1-800 numbers and access services there. That's not happening. They're doing that and Colorado Lift by OnPath on their own. And my sense is, what I'm hearing back from our Colorado Lift partners is that when people get stuck, that's when they're getting the calls. But the majority of people are going directly to the website. The second thing that I'm working on, this is like the third thing, is I am working on strengthening our client search platform. And the reason why I'm doing that, the client search platform, and I don't know how many people know this, but prior to me getting here, there was some investment in a system that would allow the public, and particularly the providers, to have information about all bed availability for placement regarding behavioral health issues. What I have found is that client search tool is not very helpful at all. All it lists is who the provider is, how many beds they may have. Well, if I am a provider and I'm trying to place a young person, I need to know how many beds, what's your service or product line that you provide services for, how many beds do you have, how many beds are vacant, and how many beds are actually offline. And those beds could be offline in 2 ways. One, they could be offline because you simply don't have enough staff, so you took some beds off. And then the other way that the beds could be offline is those beds are occupied. So what we have been doing is researching the availability of beds within the network of BHA, where we license beds, but also looking at the beds that CDHS uses when they're looking at child welfare placement. Right now, the system has approximately 2,559 beds. Not necessarily available, but we're trying to get to that by streamlining and strengthening what client search looks like. The way in which I envision this tool to be used is that if a provider is in need of placing someone in a specific system for a specific type of treatment, they're able to go onto client search and look at the availability. That's number one. No, and they should be able to place, by the way, in real time. So they would know the bed is there, they would contact the agency and try to look at what is the screening criteria or whatever. At that same time, they would shut that bed down and say, okay, this bed is offline, but here are the other beds that I have available for the behavioral health system. So what I'm trying to do is to look at this systematically so that we know what beds are really available to us to be able to place adults, young adults, and children. I've also extended that into a discussion of competency beds, particularly civil commitment, because I'm being told we don't have enough civil commitment beds. Well, I've got my staff looking into that. The reason why I give you the number of 2,500 beds in the behavioral health system between me and CDHS is I'm trying to get a sense, and I still need to do more investigation. Is that a right number? Or is the real issue we don't have enough beds for a certain type of service delivery system? And so I'm trying to figure that out. Number of beds to what we need it for to be able to serve children and adults. Right now, it's no secret to anybody. One of the places that does all the housing for us is the jails and the juvenile justice system, and that should not be. We've got to back up and figure out treatment and let jails be the last resort, not the first resort. And I don't want anybody to take away from this conversation that I'm saying if you do the crime, you just get a pass. That's not what I'm saying. I'm saying that sometimes crimes are done because somebody's not well. And we want to make sure that you're well. And if you chose to do the crime, then you really got to pay the, do the time. That's just how that is. So I wanted you to know that we're working on that. We've also been working in a collaboration with CDHS and HICPUF around competency, looking at strategies for competency in terms of when people are deemed permanently incompetent, that they are not just released from the jails, because that's what the statute says right now, but we are still keeping our eyes and being able to support them in the community. And so we are looking at developing and embellishing some already existing programs and facilities within the state system to be able to do that. So that's coming. You'll probably hear more from BHA and I about that work around competency. What it's going to mean is that we're going to have to change some of our statutes, some of our rules to be able to do some things creatively so that we're meeting that gap need of people who are deemed incompetent. And instead of just letting them go, we kind of got to figure out what the service delivery system would be, but it's going to take some statutory changes. So more to come on that. And then finally, there are 4 goals, and I might have said this to you, I don't know, and if I'm repeating myself, you could certainly tell me to shut up. There are 4 goals between August and going into December of 2026 we are focused on here at BHA. And I'd like for you to take these goals down because you're going to hear these from me and certainly from Megan and the BHA team. The first goal that we're focusing on, which is, and all of these goals are what I've heard in my visits throughout Colorado. So this isn't Danette coming up with it. This is what I've heard from the community that the community has said to me is important. First goal is access to behavioral health. no matter where you live in Colorado, you should have good access to behavioral health care. You should know where to go to get those services and how. And so access is number one that we are working on here at BHA. The second goal is developing a robust crisis system. Our crisis system is not nearly as robust as it should be. One of the states that has a very mature crisis system that we're going to go and visit, I hope, in January or February is Utah. Utah not only has physical plant crisis programs, but they do a lot of walk-in, they do a lot of virtual, and they've been able to fund a crisis system from their rural communities to their urban communities. Here in Colorado, depending on where you live, depends on how robust your system is. So let me just give an example. I've been out to Sterling 2 or 3 times. Sterling's crisis system is the police. That shouldn't be. But that's who access the crisis system. If you have a mental health break in Sterling, end up getting treatment, but decide to relocate to Denver, nobody knows that you're here in Denver and we might need to provide support. So what's the linkage from those two communities? From Sterling to Denver, from Denver to Mancos, from Mancos to Sterling. We have no way of linking people to say, if you get in crisis, if you relocate someplace in Colorado, we can still work with you. So crisis and access are the two big things that we're working on. Again, this is not all going to be achieved in 1 year. In fact, I would venture to say this is probably going to move into the new administration, and it should, because it's the two most important things. The third thing is building a robust children and youth implementation plan. I know for a fact that Tasha and Raquel know that I have not necessarily been very happy with the initial children and youth plan. And so we're putting that on steroids, and we're going to be embellishing that plan. More to come, more for you to hear. Staff are working on that plan as we speak. They have even developed, and they made a presentation to me day before yesterday on a governance model that is going to oversee how we serve children and youth in this state. It is not as robust. We wait for children to become acute instead of figuring out how we address them with prevention strategies. So you got to get sick to get access to care. That's not what we want for children. We want to be able to see some of those difficulties early on and address it then, not 10 or 15 years down the road when they're now more in an acute state. And then the final goal is the intersection between the criminal justice system and behavioral health. It's no secret to people on this phone that a lot of behavioral health services are done in the jail. Okay, fine. I can tell you BHA doesn't have a problem with that. I've done that other places in my career. However, there should be services that are done before incarceration that really need to focus on how we support that special group of young people between the ages of 20 and 40 who have serious mental illness, who have neuro-cog issues, who have developmental and intellectual disabilities. How do we address those needs? And so those are some of the things that we're putting on the burner to kind of address over the course of this next year. So BHA has been pretty busy, and we've been out there and just really trying to do some really good work, and doing that work through collaboration with many of you that are on the call, but also, with the community. I've had multiple conversations with Denver Health. We're looking at how we could work better with Denver Health. We've also, I think the last time, and if I didn't present it, I'll do it the next time that we talk. We've been doing a lot of work with Denver jails, a lot of work around licensure to really bring behavioral health services into the jails and considering them as one of our CSNPs, not the jail, but Denver Health. So a lot of work going on to really solidify access to care and a crisis system.
Thank you so much, Commissioner. So much information. Do we have time for a couple questions?
And I have just time for a couple because I got to get on another call with the governor's office. I'm sorry if I was long-winded, so I could take 1 or 2 questions.
Yeah, I'm going to let Carolyn speak. She rose her hand first. Carolyn Hall?
Yeah, yes, I would like to know, it hasn't been easy to access how people could get back, how people can get into services because I'm not able to find it anywhere. Is it on the BHA website? And then what do you look for after that? Do you look for coordinators or managers?
Right. So what I'm going to do is I'm going to have Megan send you the Colorado Lift link and also on path so you can see.
Thank you.
Yeah, there's 2, Rocky Mountain with United Health up in Region 1. Signal Behavioral Health has Regions 2, 3, and 4. Megan can put it in the chat so you can access the information.
Absolutely. Thank you so
Carolyn,
much.
I was just going to say real quick, Caroline, if you can put your question in the Q&A, that will allow me to put that link in the Q&A so that even the members of the public can receive it.
Dr. Archuleta?
Yeah, hi. So what about are we doing anything for the workforce? We've lost some of our workforce development dollars. People are leaving our field. They're not wanting to enter our field. More beds are helpful, but if we don't have people there needs to be incentives for clinicians to go to rural communities. There needs to be incentives, possible, more student loan forgiveness that would make this enticing for people to want to work in our field, and that would make it whether it's prevention educators, peers, or clinicians, it just seems like there's definitely a workforce shortage, and a lot of people feel extremely deflated. Even with us trying to do the CAS SLAC system, there's just no funding, and a lot of people can't really even afford to pay for their certifications or the tests.
Yeah, so what I would say to you is we just brought on a young lady by the name of Dr. Janine, and she has a lot of experience in not only behavioral health, but also in workforce development. So Rob, she's going to be looking at some of those strategies and sharing that with me and Dr. Rousseau in terms of what our next steps. She's just been on board for the last 30 to 45 days, and so she's finding her way, but I think we'll have some recommendations. Yeah, Duran, I call her Dr. Janine, but Dr. Duran. She's been on with us for about 45 days, and I'm sure she'll come to us with some recommendations of next steps.
Yeah, that was my question is what about what's going to happen with the workforce that's necessary to make all of those things happen? Because we're also seeing on your access, the access will be a challenge considering there's so much clinical regulations coming down that's actually going to barrier access to create a barrier right now, actually, both from a workforce standpoint, frustration, and an access point. The amount of clinical regulation coming in, it's easier to go have surgery than it is to get a behavioral health service. It's becoming easier to have like a transplant.
Yeah, and you know what, Raquel?
Care.
I think one of the things that BHA is going to have to do through a lot of our regulations is to really look at what really needs to be regulated and what could we pause on in this environment that we're in. And so we're beginning some of those conversations.
Yeah, and feel free to utilize us too,
Yeah.
Commissioner Smith too, as Rob and I have some familiarity and other providers in here. We'd love to be a part of those conversations and give some real world views to how that impacts us here on the ground. Michael, I'm going to let you go ahead, and then we have to let Commissioner go so she can meet with the governor.
Fantastic. Thank you, Raquel. Commissioner, thank you for all the work that you're doing on the safety net system, on the crisis system, on the work and within workforce. Really appreciate it, really needed. You spent a lot of years working in criminal justice and some of the things that you were talking about earlier. My question for you is, how are we supporting and increasing access for the insured middle? There's a lot of focus on the safety net, on collaboration, communication, connection, but oftentimes the insured middle, the underinsured in particular, are oftentimes forgotten, and that we are over-regulating the private sector in providing services to the population and adding requirements that are on top of and burdensome on top of what we already have with our insurance companies and those contracts. What is the BHA doing to support that side of the house?
So I would tell you that right now, I haven't paid as much attention as I probably need to. I think that that's something that we're going to have to assess ongoingly with all of the projected Medicaid cuts and its impact to even the middle class and those that are insured. I just haven't had a chance to take a really sound look at that, Michael. I'm sorry. I know I'm going to have to leave you. I'll have to come back, Michael. Next time we see you, I'll have more information, but I've got to get to another meeting with the governor's office. Again, thank you so much.
Thank you, Commissioner.
Commissioner.
Thank you. That was a great update from the commissioner. Great update to have her present. I'm grateful for a council that speaks up, though. So thanks for speaking up about workforce. All I kept thinking was great ideas. We need people who are actually going to do that work, or we can't, and none of that will actually occur. So I'm grateful for those of you who speak up about that, and even the regulation of private. So I had a therapist the other day, actually, Michael, shared that she's like, I don't know if I want to do this anymore. Great, and so that's discouraging to me in a small community.
I'll be completely transparent. I work for the private sector, and we have been approached by the BHA, required to be licensed by the BHA, and they're applying SUD rules from my previous life to the private sector, and they don't match. They don't work. It's on top of it, and it is burdensome.
Yep. Keep speaking up, Michael. I need your voice here. Please keep speaking up. You too, Dr. Archuleta, and anybody else, feel free to speak up. That's what we're here for. Megan, just putting in the chat that Carolyn's that we can't access or actually post in the Q&A. So the question that she posed, just so the public's aware, is just how do people connect to the service line so they can get into services through the BOSSOs? So that was the question.
I'm curious. So I did try to put in our chat the link to OwnPath. It says it went to everyone. If someone in the public can confirm whether you can see that or not. Perfect. Okay. Thank you.
All right. Council business. Just a reminder that this evening we have our council coffee talk this evening. I sent a reminder to everyone. If you did not get it, let myself or Tasha know. Tasha and I have an agenda, her and I'll review after our meeting today. If anybody has any suggestions, we're open to it. But if not, I guess we're seeing each other at, I haven't looked at my calendar yet today. We're at 5 o'clock this evening. Yep, thanks, Tasha. I appreciate it. Any questions about that? I'm excited to kind of get to know everybody personally. We've never done anything like that before. And just a reminder that we won't be able to speak about council business. It is literally to get to know each other on a personal level. So that we are not in violation of open meeting laws. So it's literally a personal connection about who we are, what we do, but no council business will be discussed during that time. All right, well, we are starting to plan the calendar out for the next year. Some of the upcoming agenda items over the next 60 days are in December, so next month. We'll be planning the calendar for the next year. And that's been really nice, is that we know what's coming up, the things that we want discussed. So that's an opportunity for you to give input. If there is a system, if there is you want to hear from somebody within the system particular, and we don't have it mapped out or we haven't heard from them, let us know. Whether it is, or you have any ideas about cadence and what that might look like, we would love your input. We'll be planning the calendar for the next year, all of next month, and doing a lot of that sometime in our executive committee also. In January, we'll be talking about our safety nets. And so I would encourage those that are attached or next to or connected to safety nets to have them come and be present so they can hear what the state is doing or what they're working on within the safety net system in Colorado. I always think that it's great to have us here, but we need other people than us here. So I've been doing actually a lot of private recruiting on my own on the side, asking other providers to be present at our meetings so that we have a robust conversation, especially at the end when we have public comment, so that it's not always our voices. We're supposed to be representative of the community, but we also want to make sure that the community is invited to the table. They've been hearing Rob and I say the same thing for 3 years. We could use some more people. You know, Michael, it's nice to have your voice up front and talking, because they need to hear more voices than us. It's that I always feel like the Horton Hears a Who movie, right? It's we are here, we are here, we are here. And if they just keep hearing my voice, I become white noise. So I need other voices at the table. So I appreciate that. We'll be talking about safety net in January. We are recruiting early and going to keep reminding you every single time we meet about the reporting, the subcommittee, our year report that we have to submit every year. It's actually written into statute that we submit a reflective report about our experiences, what we think we achieved or did not achieve. I always like to encourage you to go read the old ones and see the progress that we've made in that reporting and how that's grown over the last 3 years. But it is actually a great opportunity if you're even intimidated, never done it before, to try it. We didn't know what we were doing either at the beginning, but we've learned so much in the process, but it really gives you an intimate look at the things that we're supposed to be doing from a back-end standpoint here as a council, what we should be looking at every month. Any questions about the calendar planning, the safety net, or the report writing subcommittee? Tasha?
I just want to add about the report writing subcommittee, because I've been a part of that since the inception, since the first year, and we have come a long way as a council. I know the inaugural council won't always be here, so it's definitely, I strongly encourage everybody to get involved with this, or look into it, read our reports, because that's where our voices are heard with this, and it's really important. So I just want to stress that a little bit, that more council members, I encourage more council members to look into that and join us for this next year coming up. So
yeah, it's an opportunity for growth and learning. And like I said, we are not going to be here forever. We term out eventually. We can't sit here forever, and we'd love to be able to pass the baton. We've done a good setup for you, but we'd love to be able to pass it on to the next generation of council members also. It's part of our succession plan. That's a real big fancy word that we're working on. Tasha and I are working on over the next year. Catherine as well, Carolyn, who's been part of that. We have to really think about that as an executive committee. And then natural segue into the conversation of the executive committee opportunity. That again is the same people that are writing the committee report, which will just show you the same people keep stepping up. And we do want to encourage also that if you'd like to be a part of the executive committee, we build out the agendas for the week prior. We talk about council business. If there's any things that we've heard from the community. Also, with that being said, if you have things that you want, that you may not want to be able to be at the committee, but you want the executive committee to consider, please just send us an email. Tasha and I are very responsive. If I miss it, Tasha's got my back, vice versa. Catherine and Carolyn are part of that. Keith is part of that. What I really want you to do is just send us an email, and we're more than welcome to bring whatever topic you want to the table and make sure that it's discussed on your behalf. It's actually part of our roles and responsibilities as executive committee. So any issues, we're here to address those. And then we just want to encourage member engagement. You know, for our first committee, we didn't know what we were doing. It was pretty back. We just kind of I don't know, didn't say much. We were just so new that we didn't participate. We just let things be fed to us. And that's changed quite a bit in the way this council operates now. We are very much engaged. We have a great relationship with the BHA. It has taught me so much. It has grown my leadership abilities, actually, even just not even with my organization, but from a local, state, and national standpoint, that I just encourage member engagement, right? I want you to participate. If we send out surveys, we really need that. I understand that everybody may not have a lot of time. I get it. I'm running 3 organizations on top of this, so I get that. But we are wanting to be, we fought to be a committee that was actually advising and not a checkbox. And so what we don't want to do is also use the BHA as a checkbox on our resumes that we're not participating in. and make sure that we're being active and consistent and participating as much as we can. So just wanted to encourage some member engagement. It's fun too. I mean, we've made great connections. I mean, even when I'm beyond this, Carolyn's not getting rid of me. Catherine's not getting rid of me. Dr. Rob's stuck. Megan's stuck, even beyond the council. So it's a great opportunity to build relationships across the state. You too, Ryan. I see you down there. You too, Ryan Templeton. So yeah, it's been great. All right. Well, we're at 40. Look at that timing. Mwah, the clock just turned over. We got 5-minute break, and then we will come back and hear about the first budget release.
Raquel, before we go to break, I wanted to know if you want to give Ryan an option of spending his 5 minutes now and then doing the break after, since he's here. That's up to council.
Well, it's also up to Ryan. What you got, Ryan? I already kind of told everybody to get away. I saw cameras start moving, so I'm sorry.
Okay, then we'll leave it. Yeah.
I will be here.
Okay. Thanks, Ryan. We'll be back 5 minutes, y'all.
Time check, 1 minute.
What's up, Ryan? What's up, Raquel?
What's up, Rob?
Hey, can the attendees hear us right now? Yeah, I was going to say we've had a lot of people asking about the chat, or have asked me. That's what I was going to ask.
Tell me more about that, Rob.
Just that, is it visible to everybody? Are we putting resources in there? Just stuff like that.
Yes. So if panelists are putting anything in the chat, you need to make sure that you're clicking on it to go to everyone, and then everyone can see it in the chat. If we don't click that, then it will only go to hosts and panelists.
I think
Okay.
it actually, we need to, it's in the settings, Megan. Because I don't think we have a choice to do it to everyone. We only can do hosts and panelists, so it's got to be something in the text settings.
That's what the Q&A, I believe, is for public, isn't it?
Yeah, but we can't comment in a, like, we can't just post a comment like right now. And just being with public, being present, I'll tell you what's in the chat is the own path and the BASO. So that's why Rob's asking if some of those resources aren't getting to the public.
It looks like they are. I see Megan just commented that they can
can you see them,
it.
Megan?
So Raquel, before you jumped on, Sandra and I were looking at that.
Good.
And so it sounds like from what you're saying, Dr. Rob, maybe it's just, I know I'm a host, and so maybe that's why I can chat to everyone those resources. And so if there's anything that you all share, I'll go through and copy it so that it goes to the public too.
Somebody put in the chat that the agenda and meeting minutes, stuff like that aren't. I don't know if that's public. They just put it's not available.
I will put that in the chat right now. Thank you, Lily. I see that comment. Thank you, Dr. Rob.
Teamwork makes the dream work. All right, Ryan. You're up, sir.
Good morning, BHAAC. So I'm Ryan Templeton. I'm the Legislative and Governmental Affairs Director at the Behavioral Health Administration. Good to see everyone again. I love jumping on here and hearing folks talk about like, hey, what sort of influence, what sort of power does a group like this have, and making sure that your legacy remains intact here as you transition and continue to move and love you're not getting rid of me. The connections that groups like this make, I think, are so powerful. So thank you for participating in this. And yes, this is also one of those ones. Even if I'm no longer in the state, I think these types of connections last much longer than that. So appreciate all of you. So I know short time here with governor's budget release, and really want to focus a lot on what the Behavioral Health Administration's budget requests are. So setting the foundation here is that every single state agency was asked to come forward with a 2.5% general fund budget reduction. So general fund being those dollars in the general fund, not specific to the dollars that are cash funded, like the marijuana tax cash fund. Those aren't what they were looking for with reductions. It's really general fund dollars in order to create a budget balance, or a balanced budget. So every November 1st, the governor supplies the General Assembly with a balanced budget. This year it came out on October 31st because November 1st was a Saturday. So speaking of sharing things, I can give the link to the Office of State Planning and Budget's website here with where you can find every single state agency's budget, including, or budget requests, including the Behavioral Health Administration's. So with that, right, our BHA approach to our budget requests, there's 4 of them, were really to identify efficiencies gained as we transitioned to the Behavioral Health Administrative Service Organization model, and leverage those bosses for administrative savings. And we wanted to make sure that we prioritize the retention of funding that aligns with that BOSSO delivery model, as well as minimizes administrative burdens, as well as preserving existing programming. With any sort of budget reduction conversation, it's a tough conversation to have, right? There's not extra money coming. right? We are in a budget challenging year again this year. The last, I think, projections that I saw was about $800 million that needed to be found there. That's in addition to the $1.2 million from the special session that needed to happen and the $1.2 billion from the previous session. So yes, there is a budget challenges for the state of Colorado. So that, yes, even though I think behavioral health is maybe the most important thing within the budget has to be balanced across every state agency as well. So with that, just a couple timeline pieces, right? October 31st is when the governor's budget release came out. Our BHA agency briefing with the Joint Budget Committee is scheduled for December 5th. That's when JBC or Joint Budget Committee staff presents what is happening within the Behavioral Health Administration. This is not BHA staff up there. That is JBC staff talking to JBC members about what they think JBC should ask BHA to come and answer for our hearing. Our hearing is scheduled for December 16th. That we answer all of those questions and kind of present hey, here's what we're doing. Here's why behavioral health and the Behavioral Health Administration, what we're doing is important. There's not decisions about funding being made in our hearing. That is when figure setting happens through JBC, and that's in the spring. That's what creates the long bill. And then that's when things get interesting in for the General Assembly and our 2026 legislative session that starts January 14th. So with that, any immediate questions there about kind of timing as we really are in that? There are state agencies that are currently going through briefings right now, so JBC is fully active. So that's happening now.
I have a question.
Sure.
You mentioned that funding is at kind of at a standstill, and we all believe that behavioral health is so critical, but what is taking priority over behavioral health when we're talking about funding? I guess I'm perplexed. I mean, public safety is important. All these different things are important, of course, but what is taking priority over behavioral health funding?
Well, great question. And I don't necessarily think it's taking priority over behavioral health, but it's maintaining funding for other important things across all sectors of Colorado, from roads and transportation and recreation, and all of that stuff plays into the larger state budget. Behavioral health and behavioral health administration funding is a really, really small piece of that. A big piece to this puzzle is Medicaid and Medicaid expansion and people rolling off and federal changes to Medicaid and how that impacts the state's requirement to meet that Medicaid funding needs for that population as well. So that's part of the challenge, is a complete every state agencies in the same bucket of funding, and how does that get distributed across every state agency to maintain all of the wonderful things that are happening in Colorado. And so it's not necessarily a priority this versus that. It's we have a cap on what state government spending looks like from the Taxpayer Bill of Rights. So there isn't an ability to say, okay, this needs to go up, because we don't have the ability to do that in Colorado. So it's not necessarily a priority like this versus that, but it is how do we have a balanced budget, as that's constitutionally required in Colorado.
I understand. Thank you.
Yep.
Great question.
So with BHA budget requests, we have 4 of them. First one, R1, that's about BHA administrative reductions. This is about BHA staff, BHA funding for how we administer programs. Last year, if you remember, in the 2025 legislative session, during figure setting, they asked us for additional cuts to other things. This is kind of builds on those additional reductions by reducing BHA program administration. So that's how BHA staff operates. This is a $551,000 cut to BHA. This does not impact specific staff. It's those vacant positions. We are currently on a state hiring freeze, and we have some positions that aren't full. We are saying, because they're not full, here's an opportunity to take that money back as part of the reduction. This does not impact service delivery, but we see this as a, hey, it's more important to us to get money out the door to those providers that provide the direct service as kind of our, let's do everything we can to make sure that those funding streams are not impacted. And this is one of those reduction priorities there. The next one, R2, and I'll try to go quick here as I see Megan giving me time checks here. R2 being, there was a bill that passed in 2024, House Bill 24-1045, that required BHA to contract with a third-party entity to provide technical assistance to support providers seeking approval to become a behavioral health safety net provider, right? It's a lot of words there. It's essentially what Tom Miller's team in Quality and Standards does to approve providers to be safety net providers. We provide that technical assistance. This bill in 2024 said, hey, in addition to BHA providing that technical assistance, providers also have a third-party entity provide that technical assistance. That was one of those ones that's a $500,000 contract. We said we can take that completely in-house, scrap that, right? So that's our budget request too. Not a direct impact to service delivery. It does impact a contract that we have. So that's one of those ones where it's not direct behavioral health service delivery, and we saw that as a priority to make sure that in this reduction time, things like that. Another one, R3, is prioritized to sustainable funding for substance use disorder treatment. A bill in 2019, House Bill 19-1287, created a building SUD treatment capacity grant program. So that was a cash-funded program by marijuana tax cash fund dollars to support the expansion of SUD treatment, substance use disorder treatment across Colorado. The problem with that is the grant program, that there's not sustainable funding on the back end. So with that, we saw this as that opportunity to say, you know what, like there's no new funding. So even if we build out these new things, there's not really a sustainable mechanism to fund these things that get created by this grant program. So it's not impacting what the current service delivery looks like. It's impacting the potential for new things. So as I mentioned before, budget balancing was related to general fund. This is a marijuana tax cash fund program. So this is also a refinance. So we're saying take the marijuana tax cash fund, put it into a different grant funding program, and utilize the $3 million from general fund for that more robust grant program to reduce from that line. So it's actually an elimination of this grant program that has a whole bunch of very specific grant requirements, and refinancing it to get rid of that program, but refinancing it with general fund dollars to give back to the JBC for balancing. The last one, R4 for us, is right sizing the support for individuals transitioning from care. This was a bill in 2022 that requires every individual that was on an involuntary mental health certification, if they are transitioning off of that certification, that the designated facility informs the Behavioral Health Administration about that individual's transition off of that mental health certification. As part of that, if BHA identifies that that individual needs additional care coordination because the transition was less than stellar, we have a program for that. That caseload has been less than we originally thought from that bill in 2022. So part of that was giving back or reverting some of those dollars. That's a $250,000 reduction there. It doesn't impact service, doesn't impact the services that we expect. It's just that the caseload was lower than anticipated for that. So that's our 4 to get to our 2.5% reduction of general fund.
Thanks,
I know
Mike.
I just went over a lot and talked really fast.
Do we have copies of that, Megan, of those 4 priorities on the budget so that we can maybe look if the council would like to review those? Would that be helpful, council, to have those 4? Yeah, okay. So we'll
I
get
think
those
they're
4,
in one of the
the budget
documents that we
priorities.
shared. Brian, were they in one of those documents?
Yeah, the one I shared, but I will get the actual JBC folder to Megan for you to just have the actual, each one of them is like 7 to 10 pages long, so you can get all of the details and background and stuff on each one of those 4
Sasha's favorite.
requests.
Thanks so much, Ryan. Appreciate it. Thank you, thank you, thank you. We're moving on to workforce. Hi, Janine Duran.
Good morning.
Hello, doctor. How are you?
Doing well, thanks. How are you?
Great. Welcome. It's nice to meet you.
Nice to meet you. Glad
Welcome
to
to
see
BHAAC
some,
Council.
yeah, thanks. Yeah, I'm glad to see some old faces on the council of folks that I used to work with before. So Antonio, Pito, one of my buddies. I see Danielle, Megan. I met yesterday and we had so much fun at the CHI Chaz event. So hello everyone. So happy to be here and to be working with you all. So where can I start?
We have 20 minutes until we have to do public comment. So wherever I don't where did we have a presentation, Megan? What was the expectation here? Just
No
talking about the discussion
presentation,
about workforce?
really to give Dr. Duran an opportunity to share a little bit about herself. I know she is just wrapping her arms around all things workforce within BHA. And so to hear a little bit, Dr. Duran, just about where you're at so far and maybe your vision and path moving forward. I know the council has lots of questions, and just want to reiterate to our council that Dr. Duran may not be able to answer all of your questions today, but anything that she's not able to answer or we run out of time for, I will circle back and get that information out to you all.
All right, sounds good, Megan. So I will just start off a little bit about my background, and then I'll hop into my vision for workforce development for behavioral health administration, and then I will take questions. So I am Dr. Janine Duran. I am a health and human services expert, a longtime resident here in the state of Colorado, as I have been here since I was 7. I was raised in Montbello and still live in Green Valley Ranch. My background includes higher education, clinic operations management for federally qualified health centers, working in state systems management for healthcare operations for like American Cancer Society. I have worked in a lot of my workforce development knowledge came from being like the Dean of Health Sciences and Administration at Emily Griffith Technical College, as well as the Associate Dean or Associate Director of Health Sciences and Administration at Emily Griffith Technical College. In addition to that, I am one of the Masters of Social Work capstone advisors at Metropolitan State University in the College of Health and Human Sciences, Go Changemakers, as well as being serving as a faculty Senate member at Metropolitan State University. I also have a background in public health as I am certified in public health. My master's is in healthcare management administration. So it gives me an interesting lens on working in workforce development, especially in public health, because of the way that in behavioral health, because of the way that behavioral health intersects with public health and healthcare management and administration. In addition to working here,
Dr.
I do.
Duran, can I pause you
Yes.
for 1 second? Can you just slow down slightly?
Yes, I'm sorry. I'm trying to talk fast just because I
Don't
know we
worry.
have
You may
long
notice
time.
Ryan Templeton talked really slow because I'm constantly reminding him to slow down. So it's not just
Okay.
you.
All right. Well, I will slow down. I will. In addition to what informs my perspective for mental health care here in Colorado, is I do serve on the Denver Department of Public Health and Environment board. I've served on that board for the past 6 years. Still have 2 more years to go. I serve on one of our state boards through Colorado Department of Public Health and Environment for one of the advisory boards in which we advise all of the boards of health across the state on the training that all boards of health should receive. And in addition to that, I'm one of the co-chairs for Frontline Farming, which is an urban farming organization. So those things help to inform my perspective. And then finally, most importantly, my youngest daughter is on the spectrum, high functioning, and she also has ADHD. and depression and anxiety. So we have certainly been high utilizers of the system as far as psychiatry, family therapy, group therapy, individual therapy, and having to navigate those systems. So all of that to say, being a person of color that has navigated the system, being a parent, being someone that's worked in the spaces, being someone that works with students, being someone that has my own therapist, someone that community trusts, as I am also am a founder and CEO of my own nonprofit, Ducks in a Row, which addresses social determinants of health and health disparities and addresses health equity outcomes. And I've had that nonprofit for the past 10 years. So many intersections with this position. And when I was reached out to say, hey, we've got some things going on over here at BHAAC Workforce Development. Do you think that you can come in and develop a strategy for us? I said, First, I said, no, I got too many things going on. But after many conversations, I said, okay, sure, I will take this on because I really feel like this is something that I'm passionate about. So, in the time that I have been here, I've done significant amount of research on what I feel like first of all, I wanted to receive the commissioner's goals for this department, and then trying to figure out Dr. R, our chief strategy officers, what her goals were, and then looking at the governor's goals as far as our wigs were, what the governor's goals were. And then we have stakeholders, right? So everyone has some goals for this particular department. So after looking at all of those goals, what I am doing in this department is realigning so that we can have this division will be broken into education and training. We have got licensure and certification. We have retention and recruitment, and then data and analytics. Education and training, they are going to support. So we've got a lot of you know Lisa BW, who was previously in this position, and now she's really focused on education and training. So she is going to support our LMS system that we have, our learning management system, which is OwnPath, and we are currently working on bringing that to fruition and moving that from viability to marketability and functionality. So all of those courses I have asked to be added to the system by December the 31st. We will have some rural courses that will still need to be developed we have a contract that will be finished up by July, but for the most part, all of the majority of those courses will be in the system by December 31st. So after what I'm calling LMS 1.0, we're going to move on to 2.0, which will involve the actual governance. It's going to be the maintenance. We're going to have a phase where you can't just take courses and put them up there in LMS. Then you're actually going to have to do a maintenance phase where you have to go back through and ensure that information stays up to date. And so Lisa will be heading up that project. In addition to that, it's important that we are providing ongoing training and upskilling to our providers. And so that is an aspect that will be taken on by this department as well. And in addition to that, we are going to be doing a provider, well, these are not yet providers, so a training series for our folks that are not yet into the field. So we've got Spanish speaking communities. We've got our urban, what I'm calling our urban non-traditional, just because we have so many words on the naughty list that I'm not allowed to use right now. So I'm sure I'm not supposed to be using that phrase either, but I'm calling them our urban non-traditional population. We've got our indigenous, tribal indigenous, and our rural populations that have not had a seat at the table. And so really want to focus on bringing them in and ensuring that they have access and that they have providers that look like them. So one of the big projects under education and training is developing a 40-hour free training series for those populations, rural, tribal, indigenous, Spanish speaking, our urban non-traditional. And a lot of our community organizations right now that are trusted by our community members that access mental health care. Okay, some of these programs are being done by folks that are not under the purview of licensed or credentialed professionals, right? And what I want to do is make sure that we can provide the basic training for those folks because we want to make sure that anyone that accesses mental health care in Colorado has no wrong door. And some of those folks don't want to engage with our licensed or credentialed professionals, and they don't want to engage with our government systems, which is totally fine. However, we do want to ensure that if they do engage with our nonprofit organizations and their community providers, that they do that our community providers and our nonprofit organizations have the skill sets to appropriately work with these folks, right? Because right now, what I'm finding is that there's a lot of grant funding available, and we have a lot of these programs that are stood up that are saying that they are providing mental health programs, but they're not really mental health programs. So we want to make sure that they have at least the basis of knowledge to say, oh, this person is in crisis. This is what we do to help this person that's coming to our door. Or this person actually does need to be connected with a licensed professional. So we are going to, they have the skills to connect them with a licensed professional. So that 40-hour training will be available for free to all of those populations. And at the very least, they can help anybody who enters their door. Now, what I'm hoping is to be able to retain those folks for workforce because that particular training, we're working with our Colorado Community College system to then have an agreement to where if they take that 40-hour training, they can get credit towards the QBHA, the Qualified Behavioral Health Administration certificate. And then they only have to take like maybe 6 more credits on that QBHA credential, right? And then say they take the QBHA and they want to, then that's where they want to stop. Then at least they have that credential. However, if they want to continue, we're working also with Metro to articulate the QBHA into the Bachelor's of Social Work or the Bachelor's of Human Services or the Bachelor's of Psychiatry. But we want to make sure that there is a threading so that folks have the off ramps to get jobs and have economic mobility if they choose to take that credential and go into the workforce, or if they want to continue their education, that they have the threading to continue on, and matriculate through the higher education system. So that is one project that we are working on under education and training. In addition to that, we are working on licensure and certification. And when I say we're working on that, we are working really closely with our friends over at Dora because Dora takes care of, the actual licensure certification, but we are responsible for the education and training. So we are in agreement with Dora that there needs to be a centralized place of information for licensure and certification because right now it's just all over the place. There are currently 12 different licenses and certifications that you can get within the behavioral health and mental health field in Colorado. However, if you're a person trying to navigate the system as far as a student or you're a professional within the system and you want to get an additional credential, it's very difficult right now there's no access, no point of information that you can go to without really digging. So we're going to make sure that information is centralized and that someone can go to one website and say, okay, so if I am at an associate's level, what credentialing am I eligible for? Or how much education do I have to get LPC? Or what credentials, what's necessary for me to get an LCSW? We want to give them that information. In addition to that, licensure and credentialing will also be the point of contact for our institutes of higher education. Because I know as an MSW professor that, and again, I'm a capstone advisor, and last year we had a licensure event at Metro, and I had only one student that attended. And I know that for a fact because they had to miss my class to attend. And so, in speaking about licensure, it's just not something that we talk about at the graduate level. So, it's a matter of when are we having those conversations with students and giving them the information. And so, that's number one, making sure they have the information. Then number two is providing them with the support for licensure, because a lot of our students of color are not able to get licensed and credentialed because they are already working in the field, and they're saying that they have to take time away from their families and take away from the pay that they are receiving on their regular jobs in order to receive those license and credentialing. So we want to, number one, streamline the information for them and show them how to navigate the path and provide kind of navigation services for licensing and credentialing. And then number two, start working on the challenge of how is it that our students no longer have to step away from receiving a paycheck right now in order to go through the licensing and credentialing process. And I see your hand, and I just want to mention one more thing, and then I will take questions. The last couple of things are retention and recruitment. And so we certainly want to work on how do we bring more people into the fields. So I attended the DPS eighth grade career fair over the last week. I was there for 2 days and spoke with so many eighth graders. I spoke with about 250 eighth graders who expressed that they had an interest in behavioral and mental health. And they kept asking, how do we stay involved? How do we stay involved? So really coming up with a plan, and one of our communications coordinators who was there with me that day, we believe we have a good plan to engage our students from 8th to 12th grade to keep them engaged in our mental and behavioral health fields, right? So recruitment and also retention, because we have a lot of folks that are leaving from behavioral and mental health fields for multiple reasons. So how do we keep folks involved in mental health fields? And I'm sorry, it's a lot of information that I'm trying to get out because there's been so much work that I have done here over the last 8 or 7 weeks now. Retention and recruitment will also involve upskilling and a provider, I don't know if it's going to be a lunch and learn series, but I've spoken with Sobra Mesa. I'm not sure if y'all know Sobra Mesa, but they are a Latinx provider group of about 65 providers, and also going to be working with the Latinx Therapy Project. We've got Ubuntu, who is a group of Black therapists. And I'm also going to be working with Colorado Access to see if we can get some affinity group of providers for our rural and also are working with Denver. Actually, I'm going to work with our tribal and indigenous director to see if we can get some tribal and indigenous provider affinity groups as well. But our goal is to make sure that we can provide our provider groups with the upskilling that they have requested. So some of them have asked, like, how do we become a part of the BHAAC network of behavioral health entities? Or they're asking about how do they get support as far as becoming a Medicaid provider or division of insurance provider. Colorado Access has expressed that some providers are needing assistance with how do they become a medical, how do they run a medical business? Because we have providers that go from working at maybe Wellpower or JCMH, and then they want to work for themselves. And they need support as far as how do they run a medical business. So we want to be able to provide lots of those provider groups with upskilling and information for how they can be supported and retained in their profession. In addition to that, we will be developing a learning academy through the Department of Workforce or the Division of Workforce, in which we can better support our rural and tribal providers by taking out our LMS system out to those entities out in the field in the state, because we will be purchasing like our own router system and like our own 20 Chromebooks where we can go out there and do our own learning academy within those spaces and helping to provide support to providers. And the last thing I want to say about the upskilling is that I have also been asked to do special topics for school mental health, as well as persons with intellectual and developmental disabilities, so that we can have upskilling for our providers that want to work specifically with our high acuity youth, and then providers that want to work within school mental health facilities. So we will be adding specific courses to our LMS systems during the LMS 2.0 phase. Although we do have some topics around those in the LMS now, we're going to make sure that we have specific provider training series around those two topics. And lastly, we are going to add data and analytics to this team so that we have dashboard reporting so that you all can see all of this work that we are doing that will live on our website. So I know that was a lot, but yes, I am ready for any questions you may have.
Thank you. Just to keep time on the agenda that I have to open up to public comment in order for public comment to take place. And then I just wanted to say, Lindsay, I saw, Tasha, you saw, I know Rob and Michael, we all have a lot of questions. And I think what we were hoping today was to get a presentation. And so we knew where they were, where the BHA was at. And then I think we should, you're more than welcome to join us with a list of questions. I know that there are providers in the room that have a lot of questions that we'd like to and some information to send your way. So we will gather some information and send it to you. I know Dr. Rob, I know I have some questions, but we're not going to be able to have time so that I can also open up to public comment. So if you are on council and we've got questions, since this is the first time that Mr. Rand's been here, we can actually put those together and then send it. I think it'd actually be better for us to have those in writing. It's easier for us to actually follow up on the answers to those also, just so you know. It helps Tasha and I keep track for accountability reasons. Sound good, Megan?
Absolutely.
Thank you so much.
Yeah, I think that sounds like a great plan, Raquel. If you all want to put that together, I will share that with Dr. Duran and then get those back to you all. And of course, as we're planning out our future council meetings for 2026, I'm sure we'll be inviting you back, Dr. Duran.
Yeah, I think that we even talked about having like this presentation so we could get a current climate, then we would have feedback, and then we would invite you back to kind of have some so that we can see some of the results of what we have proposed as advisory council.
Yes, I could certainly do a presentation for you all. And it was just so last minute that I was invited and I was out the office the last couple of days or last week at the DPS deal. So so please forgive me for not having a presentation for you all, but certainly if that would help you, I could send you all something. So Megan, just let me know.
You're great. I think we just we're all a lot of providers in here, so we hear what you are giving us, but we also have a lot of things that we are not hearing. And so I think some of the things we want to talk about are the things that in our day-to-day are stopping us from work. And so that is part of like why we also love this feedback loop. So you can you give us information and then we kind of are listening to maybe what we need and what's missing out here. And then we'll give you feedback so then we can have that feedback loop.
And Dr. Duran, just to clarify, when Raquel's saying presentation, I think she means exactly what you just did, not that you showed up with slides. This council actually prefers this kind of dialogue.
Yeah.
And please feel free. I'm seeing some, I'm trying to look at what's in the chat, but some folks are saying that they would like to talk to me. Feel free to give my contact information if people are asking to have some direct conversations with me. I'd be happy to do that.
Cool.
I will put that in the chat. Thank you.
Yeah, I think we'll see. I think definitely it seems to me that the council is very passionate. I do know they're passionate about workforce, something that we're very passionate about this year. So we might have to create a little subcommittee of people who want to have that conversation. So we make sure we gather it all together. I know Rob, Michael, I see you. We can do that. Thanks, council. All right, we're 3 minutes past. I have to open up for public comment. Is there public present who would like to comment? I think, Megan, the process is for them to raise their hand and then you can see them. And then Megan will open it up so that you are able to share.
Looks like someone has their hand up, but I can't see. Oh, okay. I found it. Teresa. One moment and I will promote. I will. Okay, Teresa, I think you should be able to unmute and ask your question or comment.
And I apologize, half of my face is numb from the dentist, so I don't know if you can see me, but no judgment, please. I don't know if Ryan is still on the call, but I want to make sure that I understand correctly one of the things he said. Am I to interpret that the BHA is reallocating $3 million in funding that was given from HB 24/1045 to the general fund? And I question that because I'd be concerned about the legality of it, actually. I testified for that bill, and it was supposed to help with prior authorization, breaking a barrier for insurance coverage of medications for opioid use disorder. It was to help MAT expansion through pharmacies. It was to help the substance use treatment workforce, and it was to help MAT in jails. And it would be nice to know that at least the 3 million is still available for some of those objectives. So I guess the question is, am I understanding it correctly that we're reallocating money for general funds? And is that legal?
Sorry, I'm noting your question, Teresa. And I will reach out to Ryan and get back to you. As far as is that legal? I think the short answer is yes, but I don't know the details to that. So I'll get more information for you. I can connect with Ryan on that. And can you remind me what bill you were referring to?
It was the treatment bill from 2024. It's HB 24/1045. Kennedy had sponsored that and it passed.
And then Megan, just making sure that you caught a lot of the questions out of the chat, or we'll be able to get them later. You did, Tasha? Okay, just making sure someone was. Because we're going to add, especially those workforce questions to our list. There are a couple questions in the chat and the Q&A, and just making sure that we grab those as well from public for the workforce development piece. There's 3 of them. Do you see them, Megan? Just making sure.
Yes, I
Okay.
see them. I'm going to go ahead and put these in public comment. There is one that says, unless BHA is going to better monitor in partnership with DORA, the training programs where licensed and credentialed staff come from, there's no way to make sure quality providers are coming into the field. Also need to make significant changes to how people accrue hours toward licensure, as right now, there is not near enough oversight to make sure people are getting training in the services that the public actually need. So give me one moment and I will put this in our...
You'll put that. I'll read the next question too. For the workforce development piece, will there be opportunities for providers in the community to engage with the BHA on needs? Also, will the BHA be working with partners such as DORA and HIPPUF to standardize and make workforce scope and supervision standardized across all 3 agencies? I will admit it is a flippin' nightmare. Nobody knows what they're doing across agency. It's like, and then you add array to that, and oh my gosh, it's all left. What is the BHA planning to do in order to make sure providers entering this field are not quick fix band-aids and actually provide care? The QBHA certification online is one of those quick certifications that has no quality control and is instantly billable to Medicaid. And we're seeing an abuse of that service actually in the metro area. So I'm going to add to that.
So a couple things. So QBHA is not billable to Medicaid. That is not a clinical position. That is an entry level position. And so that's something that I actually just emailed COPA about this morning and asked them to review that information from their website. And I was actually on a meeting with the Colorado Community College System and the CDHE when that information was brought to our attention. And we're not sure how that information or how that rumor came about, but
I can tell you, Medicaid. HIGPUF
well,
actually released in a meeting I was in, and Medicaid themselves released that it was billable, and you watched every peer coaching practice in the state all of a sudden grab QBHAs. So that's actually where it came from. I was in that meeting.
Okay, well, there is some dissension then between the folks
That's what we're talking about. That
there's
not a consistency between those agencies.
And and someone cannot, just because they are the folks that are administering payment, cannot take a position or curriculum from an institution and then say that it's clinical. So it sounds like HICPUF needs to reach out to the Colorado Community College System that actually developed the program level outcomes for the QBHA, because the QBHA is not it's not monitored by DORA. So it's not a clinical position. So I'm not sure where that came from. And again, I sent that over to COPA this morning and asked them to update their website. So I'm saying this here, I'm saying this now for everybody to understand. QBHA is not billable by, it's not clinical. If HICPUF decides that they want to pay for it, then that is their.
There's not every clinical service, but Medicaid does pay non-clinical services. I'm a peer and I'm not clinical, and it's actually billable. So clinical is not one of the criteria to bill Medicaid.
Well, it's not clinical. Okay, I won't say that it's not billable. So if they choose to bill for it, they bill, but it's still not a clinical position.
Yeah.
So I just want to be clear on that. As far as the questions that I saw about regulation comes from DORA. So I know that that's also very challenging in the space that we live in. However, BHA only provides the guidance for education and training, but we do not regulate the certifications. All we regulate is the CAC. And so it's a frustrating space for us to be in as well. But that's why we have to play nicely in the sandbox with DORA, because DORA, they still regulate all, except for CAC, licensure certifications, any type of complaints, any type of renewals, any type of, initial registrations. All of that is coming from DORA. We can provide the information as far as how someone can receive those credentials, right? But we don't administer. We don't do anything against anyone's license. All we do is provide the information as far as education and training. And so I just have to keep on reiterating that.
Yeah. So I'm at time on my meeting, and I just want to grab, we will have more conversations, because really what's apparent is that there's not clarity, is what was the point, between all of the agencies that govern everything that we do every day. So it's like a crapshoot when we're working out here. And so I think that's when we talk about what needs to be thought about in workforce. I think this conversation is probably priority over getting more people educated and brought into a system that is not currently functioning well. So I think that's, if we don't have clear licensures, then what are we doing? And we don't have people going, we don't know what agencies doing how they're billing. I think that's a conversation that we need to have, is getting the lines clear so we understand. Because obviously there's some disconnect between DORA, BHA, HIGPUF, and all of the agencies.
I guess
anyway, we're at council.
Is there something I can send you all over to help you understand? I'd be happy to send that to you.
Okay. All righty, we're at time.
Right. I think it's not a matter of understanding. I think it's a matter of the lack of collaboration and communication across state government and how that impacts delivery on the ground. And that is where the BHA comes in as a collaborator, as a convener, to bring those entities together. At least that's what my impressions are.
Thank you, Michael.
I want to just step in. I'm sorry, we are for our council, we do have to end timely, and we're already 4 minutes over. Dr. Duran, it sounds like we will be inviting you back for lots of further discussion. And I will make sure that all additional questions that the council has come your way.
All right, sounds good. Thank you.
Bye, council. See you this evening.
Great meeting you all. Thank you.